Welcome, everyone. My name is Lauren Tobias, and I'm going to be moderating today's Yale Sleep Seminar. I have a few quick announcements to start off. In order to receive CME credit for attendance, please see the chat room for instructions. You can text the unique ID for this conference anytime until 3:15 p.m. I encourage you to make use of the chat room throughout this hour for questions, and please also make sure that you are muted. And we're going to have some time at the end for folks to unmute themselves and ask questions aloud. Finally, please feel free to share the announcements for this weekly lecture series to anyone else who may be interested, or you can contact Debbie Lovejoy to be added to our email list. Before I introduce today's speaker, I would like to take a moment to share some sad news about a member of our sleep team here at Yale and the West Haven VA. Michelle Millard, who is the manager for our Connecticut VA Sleep Lab, passed away peacefully this morning in the Yale Intensive Care Unit. Michelle was the backbone of our VA Sleep Lab, having been there since its inception over 20 years ago. She was a great advocate for our veterans. She established a deep culture of collegiality between the techs and our sleep lab. She was hardworking, and she could always be counted on to speak her mind with honesty and authenticity. Michelle is survived by her wife, Kathy, who is her partner for over 40 years, and her brother and Kathy were at her bedside this morning. I'd like to take a moment of silence to honor Michelle and her contributions to our veterans. She will be deeply missed. So now it's my great pleasure to introduce our speaker for this afternoon, Dr. Sherrie Katz. Dr. Katz received her medical degree from McGill University in 1997, following completion of pediatrics residency and pediatrics respirology fellowship at the Hospital for Sick Children in University of Toronto, as well as training in pediatric sleep medicine. She completed a clinician investigator program and Master's of Science at the University of Toronto. She worked as a pediatric respirologist and clinician investigator at the CHIO since 2003 and was appointed as a senior scientist at the CHIO Research Institute in 2017. She has served as division head of pediatric respirology at CHIO since 2018. Dr. Katz also holds an appointment as full professor of medicine at the University of Ottawa and is cross-appointed at their School of Epidemiology, Public Health, and Preventive Medicine. Dr. Katz's clinical care primarily focuses on sleep-disordered breathing, home mechanical ventilation, and complex respiratory care. Her research interests are informed by her clinical practice and primarily focus on the use of assisted respiratory technologies for children with chronic diseases, particularly neuromuscular disease and obesity. Her research also evaluates predictors and novel diagnostic modalities for pediatric sleep-disordered breathing, pediatric home mechanical ventilation, and long-term outcomes of chronic lung disease. Dr. Katz also serves in administrative leadership capacities on several national and international committees, including as vice chair of the American College of Chest Physicians Sleep Network and co-chair of the Canadian Thoracic Society's Home Mechanical Ventilation Assembly. I have personally come to know Dr. Katz through our mutual involvement at CHEST, and I can say that in addition to being a brilliant educator and researcher and a fantastic speaker, we're in for a treat this afternoon, she is deeply committed to her pediatric patients with neuromuscular and chronic lung disease. So please join me in giving Dr. Katz a warm welcome for her talk this afternoon, which is entitled Moving Pictures Worth 1,000 Words, Novel Diagnostic Tools for Pediatric Obstructive Sleep Apnea. I'll turn it over to you, Sherrie.
Thanks, Lauren. Thank you for the kind introduction and my condolences to all of you on the loss of a dear colleague. Thank you again for the invitation to speak with you. My practice is primarily centered around the management and diagnosis of pediatric sleep disordered breathing and home mechanical ventilation. The topic for today, moving pictures worth 1,000 words, really stems from the challenges in clinical practice of diagnosis of obstructive sleep apnea. And it's the clinical challenge of being able to diagnose these children that has really informed the research that we'll be particularly discussing today. So this is the code I think you need to get your accreditation. I don't have any disclosures to report that are relevant to the talk today, although I do hold grant funding from a number of agencies that I'll pop up on the screen for you in case it matters. Our objectives over the next 45 minutes or so are going to be to understand the importance of early diagnosis to prevent morbidity associated with obstructive sleep apnea in pediatrics. We will be articulating and discussing the advantages and limitations of the existing diagnostic tools for obstructive sleep apnea in children. And finally, I hope to share with you the potential role of video clips as a novel screening and diagnostic tool for pediatric OSA. So let's dive in and talk about the importance of early diagnosis. As you all know, obstructive sleep apnea syndrome is a syndrome characterized by upper airway dysfunction during sleep with snoring and/or increased respiratory effort that results from either upper airway resistance that is increased and/or pharyngeal collapsibility. OSA affects 1 to 4% of children. In Canada, that equates to 106 to 424,000 Canadian children. In the US, your population is much bigger, so 736,000 up to 3 million children are affected by obstructive sleep apnea. In certain high-risk populations, such as those with obesity or Down syndrome, the prevalence can be up to 50%. So this is a big problem, and there are many children who would benefit from the ability to have access to diagnostic services for OSA. In terms of the pathophysiology, it's really a balance of risk factors contributing, and these include neuromuscular activation and structural narrowing. This can be related, the neuromuscular activation issue can be related to central drive, but the biggest component is likely the collapsibility and the degree of neuromotor tone that exists during sleep in children's upper airways. Those who have less active neuromotor tone tend to have more trouble and a higher risk for obstructive sleep apnea. Sleep apnea in children is often sleep state dependent, much as in adults, where in REM sleep and the muscles are most relaxed, this becomes more predominant. And while we use less medications than our adult colleagues in terms of sleep issues, the medications can have an effect as well. Children have very narrow upper airways, particularly when they're very young, and they tend to be very collapsible. The other challenge that children run into, particularly between the ages of 3 and 6 years of age, is that their adenotonsillar tissue is growing and growing faster than the size of their airways. So adenotonsillar hypertrophy in young children is a major contributor to obstructive sleep apnea. Tongue size can be a factor, particularly in children who have larger tongues, such as those who have Down syndrome, and craniofacial features can dictate the structure of the upper airway and cause narrowing as well. The end result of these two components is that hypopneas and apneas occur with airway obstruction, resulting in intermittent desaturation, rise in CO2, and arousals from sleep. In children, there are typically 2 peaks of prevalence of obstructive sleep apnea. The younger children tend to present, as I mentioned, between 3 and 6 years of age when their tonsils and adenoids are at their peak size relative to the size of the airway. And particularly in older children, especially post-puberty, obesity is a major driver and etiologic cause of obstructive sleep apnea. It may be less amenable to surgical treatments and often treated with positive airway pressure. Whatever the etiologic factors that contribute to pediatric obstructive sleep apnea, which is highly treatable, we have a problem in that children are not getting diagnosed in a timely manner. And this delay in diagnosis results in substantial morbidity in the cardiometabolic, neurobehavioral, quality of life, and mental health realms. And it's morbidity that can last an entire lifetime. So I think it's important to review. From a neurocognitive perspective, we know that obstructive sleep apnea affects learning, memory, language skills, school performance, executive function, behavior, and attention. The mechanism thought to underlie this is the repeated desaturations resulting in decreased cerebrovascular perfusion and the sleep fragmentation that impairs sleep quality. We know that treatment, for example, with adenotonsillectomy, can improve cognition and behavior, but the reversibility of this is less at older ages. Cardiovascular morbidity occurs similar to in adults, and children can experience autonomic dysfunction with both systemic and pulmonary hypertension, endothelial dysfunction, metabolic syndrome, and systemic inflammation. There are several mechanisms that likely underlie this as well. The arousals that activate the sympathetic nervous system and the fight and flight response result in an increase in catecholamine release that increases heart rate and blood pressure. Respiratory acidosis and intermittent hypoxemia cause oxidative stress, inflammation, and endothelial damage. And high negative intrathoracic pressures that are generated during obstructive events increase left ventricular wall tension and myocardial oxygen consumption. We also need to talk about quality of life. It is remarkably reduced in children who have obstructive sleep apnea. The magnitude of decrease in quality of life has been measured to be similar to that of children who have juvenile rheumatoid arthritis or cancer. So pretty bad. The parents of these children are also affected by the obstructive sleep apnea, and the parents report substantial financial burden, missing work, and missing school. Obstructive sleep apnea in childhood is also moderately associated with depression, with at least twofold increased hazard ratios. Problem is that the morbidity in childhood doesn't go away, but probably compounds over time as the children grow into adults. Severe obstructive sleep apnea in childhood is associated with a twofold hazard ratio for all-cause mortality in adulthood, a twofold increase in the risk of cardiovascular events, and the risk of both incident and recurrent stroke. We know that nocturnal hypoxia increases the risk of major cardiovascular events, and that this can be treated, for example, with positive airway pressure treatment, and decreases the risk in a dose-dependent manner. So I hope I've impressed upon you that obstructive sleep apnea in childhood is a serious condition. It's fairly prevalent, and the morbidity associated with it is substantial. The other important piece to this is that the morbidity and the end organ consequences of pediatric OSA can be reversible if they're diagnosed early, but they become irreversible over time and can affect one's health throughout the lifespan. So there is a window of time for intervention to reverse these complications. One of the challenges, of course, is timely diagnosis of obstructive sleep apnea in children. So our second objective is to go through the advantages and limitations of the existing diagnostic tools. And I'll present this with a clinical problem because this is what I see in my clinic, and I suspect for those who practice in pediatrics, this is a very common scenario. A 5-year-old boy who comes to the clinic with attentional problems, snoring at night, and a history that has been going on for 2 years. The parents are incredibly frustrated because they have been waiting over a year to get a sleep study to evaluate for possible obstructive sleep apnea. And while I recognize that resources in some parts of the US may be much more available for testing than in others, I think this is a universal problem that access to testing is limited. So the tools that we have at our disposal include our history and physical examination, those basic tenets that we start with as medical students, the use of questionnaires, overnight oximetry recordings, home polygraphy, and polysomnography. And we'll go through each of these in turn, weighing the relative advantages and disadvantages of each. So first, let's start simple with history and physical exam. In children, we may pick up on history symptoms that are directly related to the upper airway obstruction itself, with stories of habitual snoring, witnessed apneas, difficulty breathing, abnormal sleep posture, often with the head hyperextended, or excessive sweating. But children may also come to medical attention because of the OSA-related morbidities and the secondary consequences that they develop. They may present with elevated blood pressures, enuresis, excessive daytime fatigue, inattention or hyperactivity, difficulties at school or with cognition, or with failure to thrive. In terms of physical examination, the most useful thing is usually examination of the oropharynx. A Brodsky score is a way of describing the degree of tonsillar hypertrophy, with 25% of the airway occluded as a tonsil score of 1, a 2, 50%, a 3, 75%, and then what we describe as kissing tonsils as a score of 4. The Mallampati score, which also describes the opening of the oropharynx and how visible it is also another way of classifying the airway itself. But despite the fact that we take our histories and physicals very seriously, the reality is that they're not super helpful in picking out the children who actually have obstructive sleep apnea. It is true that the presence of snoring and witnessed apneas are the symptoms that are most predictive of obstructive sleep apnea, but physical examination, other than perhaps large tonsils, is usually quite normal. And our clinical suspicion of obstructive sleep apnea is only confirmed in 30 to 56% of cases. So we're not very good clinically without additional diagnostic tests determining who has obstructive sleep apnea. There are several questionnaires that have been developed with hopes of better identifying its presence, and the most commonly used is the Pediatric Sleep Questionnaire. This is a well-validated, simple one-page symptom inventory that contains 22 items. It's scored between 0 and 1, and a score of at least 0.33 identifies pediatric obstructive sleep apnea. It has a sensitivity of close to 80% and a specificity of around 47% for detecting what we call moderate to severe obstructive sleep apnea with an OAHI greater than 5 events per hour. Importantly, it is able to predict key adenotonsillectomy responsive OSA comorbidities and to measure their improvement after adenotonsillectomy. So the advantages of the Pediatric Sleep Questionnaire are that it's accessible, it's low tech, and can be completed by the parent. The disadvantages are that it's less specific than other measures to diagnose obstructive sleep apnea, and it doesn't actually measure any gas exchange measures or respiratory data. If we want to try to look at gas exchange, the next option we have is to look at overnight oximetries. What I'm presenting to you here is a seminal study that was published in 2000 in Pediatrics, looking at the use of obstructive sleep apnea to diagnose OSA in children. It was a cross-sectional study of almost 350 children referred for sleep study with a question of, do they have obstructive sleep apnea? What they found in their sample was that 60% of them ultimately were proven on sleep study, polysomnography, to have an apnea-hypopnea index greater than 1 event per hour, which is consistent with the presence of obstructive sleep apnea in kids. They found that the oximetry had a positive predictive value of 97%, although they couldn't detect the severity. And almost half of those with a negative oximetry, however, still had obstructive sleep apnea when they were tested on polysomnography. They may not have had the desaturations, but they certainly had the sleep fragmentation that can result in daytime morbidity. So the wind above this was that positive oximetry is helpful. If it's positive, it's very useful, but it doesn't tell you the severity, nor does it distinguish obstructive sleep apnea from central apneas. But a negative or normal pulse oximetry does not rule out obstructive sleep apnea. There have been other attempts to try and quantify the severity of obstructive sleep apnea based on oximetry. And what I'm presenting to you here in the table are the criteria that are used for a McGill oximetry score. That's a score between 1 and 4 that describes the severity of obstructive sleep apnea. On the right of my screen is a figure that corresponds to each of these stages. So a score of 1, which is considered an inconclusive McGill oximetry score, would be a child who has less than 3 desaturation clusters to less than 90%. A 2 would be at least 3 clusters that dip below 90%, but not lower than 85%. A McGill 3 score is assigned if there are dips below 85%, at least 3 of them, but they're not dipping below 80%. And a McGill 4, the worst score, is associated with at least 3 clusters of desaturation below 80%. And this scoring system has been used to identify children who need rapid access to adenotonsillectomy, but it's also a useful tool for quantifying, based on oximetry, the severity of obstructive sleep apnea. Another way of looking at oximetry, which is the metric preferred by the American Academy of Sleep Medicine, is to look at the oxygen desaturation index. It has been found to be quite useful for detection of moderate to severe OSA, here again defined as an apnea-hypopnea index greater than 5 events per hour. It is not incredibly sensitive, ranging between 37 and 59%, depending on whether you're looking at desaturations of 3% or 4%. And it has specificity with a very wide range between 60 and 95%. There have been several cutoffs that have been proposed to look at thresholds that would be considered positive or high risk for obstructive sleep apnea. Most of these are related to an ODI of 3%, so looking at the number or the index of desaturations of at least 3%. And cutoffs of above 4.3 events per hour and above 7 events per hour have been described in the literature to suggest abnormality. I want you to remember these numbers because when we come back to look at other methods of evaluation of obstructive sleep apnea, we'll be comparing them. There's been a meta-analysis done, several actually, looking at studies of overnight oximetry and pooling the sensitivity and specificity for moderate to severe OSA using both the ODI-3 and other parameters. And they found that the pooled sensitivity is about 83% and specificity 75%. So not terrible, better than the questionnaire, but certainly not perfect. There's also been a push recently to look at oximetry-based machine learning algorithms to see if we can automate the evaluation of the oximetries, and these had sensitivity of 74% and specificity of 90% for moderate to severe OSA. This is one type of cloud algorithm-based oximetry-based diagnosis using a Bluetooth oximeter linked to a smartphone. And the reason I put it up here is to show you the areas under the curve, which range between 0.78 and 0.9. So in total, the advantages of overnight oximetry are that it can be done in a home environment. There are limited sensors, which for many children makes it much more tolerable of a procedure. Children like to take off sensors and sometimes are quite afraid of things coming onto or towards their bodies. And oximetry in general is more accessible than a full polysomnogram or a polygraphy. The challenge with this approach is that the artifacts are harder to discern in terms of knowing exactly what's happening when there's a desaturation, whether the child may be moving or the probe dislodged that may be affecting the results. The averaging time of the oximeter may affect the detection of short events. If the averaging time is long, short events may be missed. In Canada, at least, there's a cost to families. In the US, I realize that people are more accustomed to paying for healthcare. In Canada, we kind of take it for granted that everything is covered under our universal healthcare system, and it's rare for families to have out-of-pocket expenses to access diagnostic tests. But this is one that is not covered under our healthcare program and is an additional cost to families. The oximetry, if it's normal, does not rule out obstructive sleep apnea. Again, we missed almost 50% of the cases when we were looking at the original study of oximetry, and it can't distinguish obstructive sleep apnea from other types of sleep disordered breathing. So let's step it up a bit further in terms of the detail that we look at and look at home polygraphy. Now, home polygraphy in children has not caught up to where it is in adult medicine as a diagnostic tool. And I think there are probably several reasons for this. While polygraphy measures airflow, respiratory pattern, and oximetry, it doesn't measure arousals. And many young children with OSA will not have profound desaturations, but they will have very severe sleep fragmentation. So they may actually have a very high apnea-hypopnea index without exhibiting the desaturations. And the polygraphy doesn't measure either the arousals or the presence of hypercapnia. It's not fully validated in pediatrics, although there are more and more studies coming out showing that it is a useful tool, particularly for the diagnosis of moderate to severe obstructive sleep apnea, and it's recommended in the European Respiratory Society guidelines for OSA, particularly when polysomnography is not available. The advantages of the polygraphy are, again, that it can be done in a home environment where children may be more comfortable and have a better night's sleep. It's less expensive than polysomnography and requires fewer resources in terms of access to a lab, a technician, and interpretation time. It does measure respiratory pattern and sleep quality in addition to the oximetry data, so it is a step up in the information that we get. And it's certainly the best option we have for detection of obstructive sleep apnea when a full polysomnogram is not available. The disadvantages of this approach are that we will know the total recording time rather than the total sleep time that a child has, and it may include periods of wakefulness that can confound results. It also doesn't detect hypoventilation because it doesn't measure CO2, doesn't detect the arousals, which is the problem of missing the kid who has sleep fragmentation but no desaturations. And there's a risk of study failure that's been ranging from 3 to 18% due to displaced sensors. If the child's pulling them off in the middle of the night, it is unlikely that the parent or caregiver is going to be in a position to replace them regularly. Whereas if this were to happen in a sleep laboratory, there's somebody there to attend to them and replace the sensors. So it has been endorsed as an option for moderate to severe obstructive sleep apnea, as I mentioned, and this is the guideline I was referring to from the European Respiratory Society. So finally, the last option that I'll present to you is polysomnography, which is really considered the gold standard. It's the most comprehensive way of measuring obstructive sleep apnea in children. It's endorsed by the American Academy of Pediatrics, the American Academy of Sleep Medicine, and the European Respiratory Society. It tends to be a very labor-intensive proposition, which is part of what limits its availability. Whereas in an adult laboratory, many patients may be set up with one technologist or respiratory therapist attending to them. In pediatrics, the ratios of patient to tech is typically 1-to-1 or 2 patients to 1 tech at best. The other thing I'll just pause to point out here is the classification of OSA severity, which is quite different than in the adult world. What we consider in pediatrics to be normal is an apnea-hypopnea index of less than 1 event per hour. Between 1 and 5 events per hour is considered mild obstructive sleep apnea, known to be associated with the morbidities we discussed earlier. Moderate obstructive sleep apnea would be 5 to 10 events per hour, and severe would be greater than 10. There have been different classification systems that report looking at the total apnea-hypopnea index. Some look only at the obstructive apnea-hypopnea index to come up with this classification. But as a general guideline, this is the range of number of events that are considered to be important in pediatrics. So while I've told you that polysomnograms are the best way to diagnose obstructive sleep apnea, we have a challenge of access. What you have here is a map of Canada with the number of sleep physicians, which is marked as a T, the number of potential sleep studies that can be done, polysomnograms, per year, and the provincial population. In Canada as a whole, we have the capacity to do 8,100 polysomnograms per year. If we assume that prevalence of 1%, and I told you it's 1 to 4% in the general population of children, we would be able to study, or we would need to study 76,000 children to identify only those with sleep disordered breathing. And we all know that not every child coming through the lab is going to have sleep disordered breathing. Even if we only studied children who were affected with sleep disordered breathing, we would have 9.5 times more children who needed the test than capacity to run the polysomnograms. This is a survey that we conducted this past year. We conducted a similar survey in 2014. And while it's true that the recognition of obstructive sleep apnea as an important health problem has increased, and the desire to have sleep studies for these children has increased, the gap between the resource and the capacity to run these studies has only increased over time. And I suspect the same is true in many other countries around the world. So when you can get it, the advantages of a polysomnogram are that it will give you the most detailed information with gas exchange information, breathing pattern, and sleep architecture. Children are under direct observation, which both serves to inform clinical impression, but also make sure that the leads stay put and we get quality data. We have an ability during the polysomnogram to initiate and titrate positive airway pressure, directly seeing the impact of changes. This again is the method of diagnosis recommended by the AAP, AASM, and ERS as their diagnostic tool of choice. And we know that the polysomnogram is useful to help predict perioperative risk and cure rates. The challenges, of course, are the limited resource, which is not always available, the disruption to the family and to the patient who have to come sleep in an unfamiliar environment for a night. The child may not sleep as well in an unfamiliar environment, so their sleep quality may not be representative of what's happening at home, and this is a costly endeavor. So what we're left with is a demand for something better. What we really need is a widely accessible triage tool that reliably identifies the children most likely to have moderate to severe obstructive sleep apnea so that they can be prioritized for definitive testing with polysomnography and resources can be appropriately allocated. This would improve access to care by reducing the backlog that we have for polysomnograms. Wait time at our hospital can be up to 2 years if it's a non-urgent referral. And it allows us to earlier identify the most severe cases so that they can be treated before they develop that irreversible end organ morbidity. So here comes the video clips part of the talk. And so we've looked at this as a research tool to see if what we see in a video that a parent records at home will help us to better identify obstructive sleep apnea. And what I'll share with you here is a video with permission of the family that demonstrates all of the key features of obstructive sleep apnea. I'm hoping the sound works. It did in our checks. You'll have to be patient a little bit because it is silent at the beginning as this little guy tries to breathe, doesn't achieve any airflow. And then you'll hear him gasp. You'll be able to see his chest retract. You'll hear him snort and snore, and you will see him really trying very hard to move air without success. So I'll play this little video for you. You can see the chest retractions there, the paradoxical respiration. So he's trying, and there's not much airflow and not much air moving. And so this really is the impetus to try and see if, better than a parent's description of what their child is doing, if we could see it directly, would we be better able to identify it? And to me, if you see obstructive sleep apnea like this, it's fairly obvious, and we know there's a problem. So it may be a telling tool that can be used for triage. The idea for this should not be credited to our team, but rather to a brilliant group of researchers in Australia who published a pilot study a couple of years ago in 43 children between the ages of 2 and 14 years. And what they developed is what they called the Monash Obstructive Sleep Apnea Video Score, which you'll see in this table, allows a score of 1 to 8 based on the presence of inspiratory noises that are rated as none being a 1 and 4 being very loud and stridorous noises, the presence of obstructive events, increased work of breathing, mouth breathing, and neck extension. And they used this tool to try to predict children who had moderate to severe obstructive sleep apnea defined here as an obstructive apnea-hypopnea index greater than 5 events per hour. And what they determined was that the kids who had a Monash score of at least 3 had a sensitivity of 100%, specificity of 36%, positive predictive value 53%, and a negative predictive value 100%. Now, this was a small sample, but it certainly seemed promising. And so we've built on this, and while we've studied the use of video clips in numerous populations, the data I'm going to present to you today was from what we called the Katz study, capturing obstructive sleep apnea using personal mobile technology in children. And this was a pilot study that we ran with funding from the Chest Foundation. The goal of this study was to evaluate the diagnostic characteristics of mobile video clips for detection of moderate to severe obstructive sleep apnea. Our hypotheses that were that the diagnostic characteristics of the video clips for moderate to severe OSA would be superior to those of oximetry and/or questionnaire, and that the combination perhaps of the overnight oximetry and the video clip together would be best to predict moderate to severe OSA in children. More specifically, we had a number of research questions that I'll walk you through. We aimed to estimate the area under the ROC curve for moderate to severe OSA based on video clip as compared to the gold standard polysomnography. And holding the sensitivity at 90%, we wanted to know what the specificity of the video clips was for diagnosis of moderate to severe OSA. And similarly, if we held the specificity at 90%, what was the sensitivity of the video clips for diagnosis of OSA? We wanted to look at the benefit of the oximetry in addition to the video clips in terms of the sensitivity and specificity, the benefit of the questionnaire, the oximetry, and the video clips together, and finally, to compare the diagnostic characteristics of the video clips alone with the combination of measures to see if we could do better. This was a cross-sectional method comparison study, and we included a population of children between the ages of 3 and 18 years who were referred to the CHEO Sleep Lab for evaluation of suspected obstructive sleep apnea, and they had to have a parent with access to mobile technology. Now, we discovered that at least 93% of North Americans had access to mobile technology, so this really wasn't a barrier for anyone in the study. We excluded those who would be unable to cooperate for a polysomnogram if a clinician suspected a different type of sleep-disordered breathing, central sleep apnea, or hypoventilation, if a child was already using positive airway pressure therapy or a tracheostomy, or if a parent didn't speak English or French. And so the approach was to have the parent record a 2-minute video clip on 3 occasions during the course of 1 week. We asked the parents to record the video clips either 2 hours after sleep onset or at 5 in the morning because we were hoping to maximize our chances of catching the child at their worst during REM sleep, although we have no way of knowing for sure if that is in fact the case. What we did do then is compare the video clips to polysomnography data. There was another study because this all got underway just as the pandemic was hitting and our sleep lab had to close down. So we did do other studies looking at the comparison of video clips with polygraphy. I'm not going to share those with you today, but we do have that data and it was similar in terms of the outcomes. And the outcomes that we were looking at again are the diagnostic characteristics of the video clips compared to the gold standard, which for this study is polysomnography. So children were recruited and provided informed consent and where relevant assent. The parents recorded the videos at home, and then the child came for the night of their polysomnogram, during which the parent completed the pediatric sleep questionnaire. What we looked at again was the video clip score, and we used that Monash score between 1 and 8. The scores were looked at by the video clips rather, were evaluated by 2 independent pediatric sleep clinicians blinded to the sleep study results. And where there were discrepancies, we developed a consensus. We were actually pretty good at having similar results, and I'm not going to share with you this in detail either, but I will tell you that our inter-rater reliability was very high. And in terms of the polysomnography, we looked at the obstructive apnea-hypopnea index as our metric of choice, defining moderate to severe OSA similar to the previous studies with an obstructive apnea-hypopnea index of at least 5 events per hour. And we also looked at the presence of any obstructive sleep apnea, which we defined similar to the CHAT study, which is a seminal randomized controlled trial in pediatrics of OSA, and we looked at their definition of an obstructive apnea-hypopnea index of at least 1.5 events per hour. The secondary outcomes, again, that we looked at were the screening performance of oximetry metrics. And for this, we chose to look at both the ODI-3, that oxygen desaturation index of at least 3%, and the McGill oximetry score that I showed you before. We also looked at the pediatric sleep questionnaire. So here's what we found. We ended up including 41 children in this pilot study with a median age of 7 years, about half of whom were female, and their obstructive apnea-hypopnea index median does not seem very high at 0.6, but 40% of them had mild, at least mild obstructive sleep apnea, so any obstructive sleep apnea, and 12% of them had moderate to severe OSA. The other things that I'll point out to you here are the thresholds, again, that we mentioned before of an ODI-3 greater than 4.3 or greater than 7, both of which have been included to identify children with obstructive sleep apnea, and between 15 and 20% of our children met those criteria. Only one of them had a McGill oximetry score of at least 2, so we didn't identify many there, but 88% of them had a pediatric sleep questionnaire score above that threshold of 0.33 who would be considered to have obstructive sleep apnea based on the pediatric sleep questionnaire alone. And 61% of them had a Monash video score of at least 3. So what does this actually mean? If we look at the sensitivity and specificity for detection of moderate to severe OSA in these children, our Monash score had a sensitivity of 100% and specificity of 20%, translating to a positive predictive value of 44%, negative predictive value 100%. So if children didn't have a positive Monash score, they were very unlikely, or were not likely, to have obstructive sleep apnea. If we compare this performance to the pediatric sleep questionnaire, which was also very sensitive, the specificity is modestly better, but we didn't do as well as the oximetry metrics in terms of the sensitivity and specificity. If we look at this a different way with ROC curves, what you see in turquoise is the Monash score, which is here, which had an area under the curve of 88%. So as good as the original oximetry metric studies that I showed you that looked at cloud-based automated detection of events, not quite as good as the ODI-3, which had an area under the curve of 97% in our study, but better than the McGill oximetry score and better than the pediatric sleep questionnaire. If we combine the metrics, we see that the Monash score, in addition to the ODI-3, modestly improves our area under the curve, but then it approaches 98.3%, which is pretty good. If we look at the identification of any obstructive sleep apnea, so this again was the obstructive apnea-hypopnea index greater than 1.5 events per hour, we see that the sensitivity and specificity are not, the specificity is better, but the sensitivity is not quite as good. We still perform better than the pediatric sleep questionnaire, but the specificity does not approach that of the McGill oximetry score or the ODI-3. And similarly, when we look at the areas under the curve, the Monash score performs better than the McGill oximetry score, better than the sleep questionnaire, but not as well as the ODI-3. And in comparison, when we look at the best option we have for combining metrics, the Monash score along with the ODI-3 give an area under the curve of 88%. So in summary, in the identification of any OSA or moderate to severe OSA, the Monash video score is very sensitive, but less specific. The video scores perform better than the pediatric sleep questionnaire for the detection of moderate to severe OSA, but less well than the oximetry metrics. And the combination of video clip score with the ODI-3 showed excellent diagnostic characteristics for detection of either any OSA or moderate to severe OSA. The limitations that we have in this study is that we're reliant on a 2-minute video clip the parent is capturing. There may be night-to-night variability in both what is captured on the video clip as well as what's captured in the sleep lab itself. It's a small sample size, and this population includes only otherwise healthy children. As I mentioned earlier, we have ongoing pilot studies in children with Down syndrome, those with obesity and autism that'll be reported separately. But what we have embarked on is a large multi-center study in otherwise healthy children to further explore this. We've got 4 centers that will be recruiting children over a 5-year period to get a much larger sample size and hopefully be able to refine the role that video clips will be able to play in the diagnosis of obstructive sleep apnea. I'd like to express some thanks to the participating children and families in our research studies, all of my collaborators, for research and clinical colleagues, mentors who started me on this path, and of course, my family. And I'll leave you with this picture of the Rideau Canal Skateway, which is the longest outdoor skating rink in the world. It is currently open because it is sufficiently cold in Ottawa for the ice to have frozen, but you can skate along 5 miles through the city of Ottawa, and it's quite glorious in February, so I would highly recommend a visit. And with that, I'll stop, and I'm happy to answer any questions.
Thank you so much for that wonderful talk, Dr. Katz. You have given me personally a recommendation for our next winter vacation here, and I'm excited to check that canal ice skating. So I'd like to open it up to questions from the audience, and while people are thinking and posting, I would just like to congratulate you on that work that you're doing. I think we all have this question in different populations and different countries about how to make sleep testing more accessible, and the widespread use of phones, smartphones, makes this really promising, really exciting results. I know you mentioned at the end you're going to be doing some follow-up work to look at these populations, but I'm just curious to hear, what are your thoughts about where this might first be practically rolled out, either what population or how could this kind of see prime time implementation?
Sure. So anecdotally, I can tell you that this works quite well in children who are otherwise healthy, probably a little bit less successfully in children who have other risk factors, such as those with Down syndrome, though we're still analyzing our data and looking at those results. We've already started to implement this in clinical practice, in that we will ask parents who come in for a sleep consultation to bring in a video of their child sleeping, and often it's quite telling. I think when the video is abnormal, it's quite helpful. If the video is not as telling, then you're not necessarily any further ahead, but it's an easy thing to ask parents to do. Ultimately, I can see this being incorporated into the triage process for our sleep studies, because we get far more referrals and we're able to study over the course of a year. But at least you could pull the kids who have the scariest videos up to the front of the list and leave the other children who are not as worrisome waiting a little bit longer. And I think, to be honest, that's probably the value we're going to get from it. To date, it looks like the negative predictive value is very high. So if we are not seeing something on the video, it's less likely that we're going to be missing something. And I think that allows us to worry a little bit less about the kids that are waiting.
That is so helpful. I see a hand up from Dr. Canapari. Feel free to unmute yourself, Craig.
Hey, Sherrie.
Hi, Craig. It's nice to see you.
I know it's been a while. Super interesting work. I actually have 2 questions.
Sure.
First off is, so say in the clinic you're getting a positive result on this. Are you then having the patient skip to the head of the line to do a sleep test, or say sending them to ENT? Like, how are you incorporating this in your practice now?
It is an excellent question, and I will tell you that there isn't a protocolized answer to that. And I think it largely speaks to the resources that we have at our disposal. Right now, and it was not the case 6 months ago, but there's been a new ENT hire in our hospital, which means that their wait lists are quite a bit shorter. than ours are. So the children who are under the age of 7 or 8, who have enormous tonsils and a positive video, many of them are getting directed directly to ENT for evaluation. And our ENT surgeons are also looking at the videos and making surgical decisions on that basis in many cases, because we can't access diagnostic testing. Where it's a little bit less clear, or we're worried about somebody, we may be able to get them into the sleep lab. Of course, that's the first choice. If we can't, then sometimes they get redirected to get an oximetry study while they're waiting, and we use that to further triage or direct care as needed. So in a perfect world, they would go video clip, sleep study, intervention, but within the confines of the resources that we have at our disposal, that's how we've managed it at our center.
Yeah, we don't have the problem with scarcity for sleep studies quite in the way that you do. But for younger kids, like really little kids, it's still a substantial wait.
Yeah.
And sometimes again, we're not researching this, but parents often do bring in videos, and it's like it looks like a duck and it quacks like a duck, and there's such a
Yeah.
And the Chervin data from the past suggests too, if the kids snore loudly and they have daytime symptoms, they're probably going to benefit from the surgery as well.
Yeah.
I mean, sometimes it's hard. You get the test and the test is negative when you're like absolutely convinced the kid needs their tonsils out, right?
Yeah.
The added wrinkle is sometimes the private insurances now are requiring sleep tests. Not consistently, but I'm sorry, ENT colleagues are pushing for tests, even in kids where I'm like, they probably just need the surgery.
Yeah.
The other thing is I saw that our colleagues in like the UK doing a lot more with home sleep testing in kids,
They
and
are.
even some interesting work on using incorporating video into that. And I think for them, it was more looking at sleep and behavior, right? But when have you given any thought to using overnight video or audio recordings, which obviously would be cumbersome to have people score, but maybe machines could do it?
So there is a study, it's an older study out of Israel that was a pilot study that looked at overnight recordings. So they were actually pretty good at diagnosing obstructive sleep apnea. Now, it was the video recording without any additional gas exchange or airflow measurements, but they were quite good. The challenge, of course, is the interpretation of all of this. And you're quite right that it's the time and labor that would be required to evaluate all of these things. If it can be automated, great. I mean, my own personal hope is that one day these video clip 2-minute videos may be having an automated evaluation so that it's quicker to do in a clinic setting. Certainly, if we're able to do it fast, more data is better.
Well, thank you. That's great work.
Are we doing any home sleep testing for peds at Yale? I'm too far removed from that world to know.
Well, we don't get insurance coverage for less than 18. In rare circumstances where we've had children where it's a hardship for them to come in, or they've had a bunch of testing and we just kind of want to take the temperature of something, we've done it. We don't get paid for it, which, I don't really care about, but our masters at the hospital are very interested in that sort of thing. So we do it very sparingly. I would not be surprised if home sleep testing for healthy adolescents gets the nod from the ASM in the next 5 years, but we'll see.
That would be great. I mean, I would imagine there's a whole lot of teenagers who would be perfectly fine, if not much, as teenagers much prefer to have this done in their own bedroom.
Yeah,
Right.
I mean, the other trick is sometimes the devices don't come back, as you know, which is also can be a challenge.
Yeah. Great. Well, I want to just thank you, Dr. Katz, for a fantastic talk. And then, I'm seeing a question. I'm sorry, I'll take one more question from Stuart Mena. What is the ideal time to get he said 10-minute, but I think 2-minute video clip? Does it depend on the normal wake up time for the child? So do you give instructions about the timing of the clip?
So there's no perfect solution to this. It's a guess and a guesstimate, but we kind of figured that if they're about 2 hours into their sleep, whatever time they go to bed, that we're more likely to capture them in REM sleep. Whether we actually do, we don't actually truly know. Or similarly, if it's 5 in the morning, they may be more likely to be able to be observed in REM. I don't think we had any parent record at 5 in the morning, just throwing it out there of the kids that we suggested. Usually the parents are recording after the child's fallen asleep, before they go to bed, roughly an hour or two after they go to sleep. But there isn't really a magic answer to this that I can tell you with confidence now.
Great, thank you. And I want to ask, I want to let people know about our talk for next week. So next week, March 5th, we're going to have the first of our 4 Yale Sleep Fellows sleep seminar talks. It's going to be with Cassandra Mullen, and she's going to be discussing sleep and athletic performance. So I hope you can all join us for that as well. Thank you, and enjoy the rest of your afternoons.
Thanks, Lauren. Thanks for having me.
Bye, take care. It's good to see you, Sherrie.
You
Take
too.
care.
Bye.